Before starting the session, I would like to welcome our speaker this evening. Dr. Maheshika Vijayawardena graduated from the Faculty of Medicine, Colombo, and obtained his DSc as well as the MD from Postgraduate Institute of the University of Colombo. He obtained his MRCP-CH from the Royal College of Pediatrics and Child Health in London and Dr. Maheshika held the positions of Eastern Province Coordinator, Sri Lanka College of Pediatricians. Without further ado, I would like to hand over the proceedings to Dr. Maheshika to deliver this evening presentation. Over to you, sir.
Hello, Lakshita, can you hear me?
Yes,
Right.
can hear you, sir.
So I'll share
you
my
can share
slide.
your screen. Yes.
Yeah. You can see the first slide, no?
Yes, sir. It's clear now.
Right. Okay.
You can start.
Okay. Thank you very much, Lakshita, for that kind introduction. As you know, my topic for today's lecture is iron deficiency and boosting immunity during the COVID-19 pandemic. So before I start, I will give a brief overview on my lecture. That is, first I will be discussing on boosting immunity for COVID-19 and what are the general ways and what are the more specific ways. And then I will talk about some research on iron and COVID-19, and then iron and immunity, and then move on to iron deficiency. And I have to mention at the beginning, I have no conflict of interest, and during my presentation I'm not trying to promote any products. If you have any questions during the presentation, you can type them down in the chat box, and at the end we'll try to answer them. Right. So what are the general ways of boosting the immunity? So we can have a balanced diet, take enough fluids, and do regular exercises, and avoiding obesity and maintaining healthy weight, and taking adequate sleep, and try to reduce stress. I don't know how practical that is, depending on what you do, right? So try to reduce the stress, use various ways, whatever you can, and quit smoking, avoid smoking and alcohol, right? Smoking is a significant risk factor to get bad COVID-19 disease, right? So as a result, studies have shown that people who smoke tend to have bad COVID-19 disease. And as a result, in some countries, when they started vaccinating the population, they gave priority to smokers, right? And then other important ways of preventing infections, as we know, wearing masks, social distancing, and proper hand washing. And then other minerals and vitamins. Studies have shown certain vitamins and minerals to be effective in boosting your immunity. These vitamins include vitamin C, D, A, vitamin E, zinc, and selenium. And meditation and yoga also were found to be effective in boosting your immunity. And other native medicines also has been tried, like coriander, turmeric, garlic, cumin, and various sort of like herbal teas. And inhaling steam has also like it was found to be effective getting rid of this virus from your nasal cavities. However, so all these measures are general measures, but most effective way of boosting your immunity against COVID-19 is to get the vaccine itself. So this table shows the some of the vaccines which are available for us at the moment. And mind you, all over the world, there are around 200 vaccines being developed at the moment. And these ones shown here are the leading vaccines, and they include like the one we got here, like Oxford AstraZeneca vaccine, and then ones manufactured in USA, Moderna and Pfizer vaccine, and Sputnik V vaccine. So Moderna and Pfizer vaccines are RNA vaccines. So they have the genetic material of the this virus. So because this mRNA and this is RNA vaccines, they are not that stable. So you have to store them at a very low temperature. So it poses a practical problem for certain countries to when you store and transporting these vaccines. But on the other hand, this Oxford AstraZeneca vaccine is a viral vector vaccine, and it's a genetically modified virus. So they have taken cold virus, that is adenovirus, and incorporated this viral genetic material into that, and made this vaccine. So both Oxford AstraZeneca vaccine and Sputnik vaccine can be stored in a regular fridge. And mind you, like, so this Oxford AstraZeneca vaccine, it was for the Southeast Asia, it was developed in Serum Institute in India, and that's what we got under the name Covishield. And all these vaccines, like when you compare the prices, you can see Oxford AstraZeneca vaccine is quite cheap compared to the other vaccines. And all these mentioned here can be given to patients with various forms of immune deficiencies, because there's no virus there in these vaccines. So then there's another Chinese vaccine, Sinopharm vaccine, which is a killed virus. It contains killed virus, but these vaccines are not there's no virus in that vaccine basically. So as a result, like immune deficient patients can't develop the disease by getting these vaccines. Okay, so then we move on to some research findings. So iron metabolism and anemia may play an important role in multiple organ dysfunction syndrome in COVID-19. And then there had been like studies have shown significant difference in mean ferritin level between the survivors and non-survivors of severe COVID-19 infection. And this alteration of this iron homeostasis can persist after 2 months of getting COVID-19. And one meta-analysis showed hemoglobin levels are found to be significantly lower in patients with severe COVID-19 disease. So that is patients who had low hemoglobin levels had severe COVID-19 disease. Again, some studies have shown low serum iron concentration to be an independent risk factor for death in COVID-19 patients. So those are some research findings, and actually at the moment there are only limited research done on these subjects. So immunity and infection, what is the role of iron in immunity and infection? Data on impact on iron supplementation on immune function and susceptibility to infection are actually mixed. So one hand, if there's iron deficiency, you can get mild to moderate defects in leukocyte and lymphocyte function. Again, iron supplementation can increase the risk of certain bacterial infections, and also they can reactivate supplementation can reactivate dormant infections like malaria and tuberculosis. So iron deficiency is the most common nutritional deficiency in children, and global prevalence is around 33%. That was 2010 data. And prevalence of anemia in Sri Lanka in less than 5 years group is around 15%. This used to be somewhat higher some time back. And then highest burden is seen in children who are less than 5 years of age. And iron deficiency is a very challenging problem for resource limited nations in Asia and Africa. So we'll look at the definitions. So what is iron deficiency? So that iron deficiency is the insufficient total body iron to maintain normal physiologic function. So the iron stores are basically below normal limits. So the cutoffs are given in this table. So up to 5 years, if serum ferritin is less than 12, we take as iron deficiency is there. And in more than 5 years group, if serum ferritin is less than 15, we can say there's iron deficiency. So anemia. So what is anemia? So anemia is the hemoglobin concentration that is 2 SD or more below the mean for for a healthy population of the same gender and age. So these are the thresholds are shown in this table. You can see 6 months to 5 years HB level cutoff we take as 11, 5 to 12 years 11.5, and 12 to 15 it's taken as 12. So what is iron deficiency anemia? So iron deficiency anemia is combination of both. So hemoglobin is low and also iron stores are also low. Serum ferritin is also low. So you can see that when you look at the table, right? So what is the prevalence? So Asian children have higher rates of iron deficiency, and there are various risk factors like low birth weight, prematurity, and childhood obesity. So how childhood obesity can lead to iron deficiency we'll discuss later on. In certain part of the world, so this anemia can range from 45 to 65%, and up to one third to one half of this anemia is thought to be due to iron deficiency. So iron, as you know, it's an essential nutrient, and most of it is bound to up to 75% is bound to heme protein, hemoglobin, and myoglobin. And remainder is bound to storage proteins, that is ferritin and hemosiderin. Only a smaller portion, around 3%, is bound to critical enzyme systems such as catalase and cytochromes. So in a healthy adult, only a small portion of their daily iron requirement needs to come from dietary sources, that is around 5%. The remaining is met by breakdown of older RBCs in the reticular endothelial system. And as a result, only a small amount of iron, that is roughly around 1 to 2 milligram, enters and leaves the body each day. However, when you consider the infants and children, up to 30% of their daily iron needs to come from diet. Why? Because they are rapid growth and increase in body and muscle mass. So iron homeostasis is primarily regulated at the site of intestinal absorption and transport. So rather than excretion by the liver or kidney. So absorption is regulated by this peptide hormone called hepcidin, and serum hepcidin expression, and therefore intestinal iron absorption is influenced by various factors like body iron stores, erythropoietic rate, and bioavailability of dietary iron. So low iron stores results in hepcidin suppression. So if there's iron stores are less, hepcidin levels will be also less. As a result, there will be more iron being absorbed at the duodenum. So what are the perinatal risk factors? At birth, healthy term infants have iron stores of approximately 75 milligram per kg, and 2/3 which is bound to hemoglobin. And as you know, newborn babies have a higher hemoglobin concentration compared to adults. They have a hemoglobin of around 15 to 17. So as a result, they have enough iron in their system to last for 5 to 6 months. However, several conditions in the perinatal period can increase the risk of iron deficiency anemia during this first 3 to 6 months of life. These conditions include maternal iron deficiency, fetal maternal hemorrhage, twin to twin transfusion syndrome, and other hemorrhagic events, prematurity, and administration of erythropoietin for anemia of prematurity, and insufficient dietary intake of iron during early infancy. So, one important way of preventing this anemia is is the practice called delayed cord clamping. So, what is this delayed cord clamping? So, in a healthy baby at birth, the baby is born in good condition. What you can do is you can keep this baby in a lower position than the placenta. So, up to 1 minute. So, the excess blood will flow from the placenta to the baby. But however, you can't do this if in an unwell baby who need resuscitation. You can't do that. But a well child, you can easily do that. And by the way, it is being practiced in UK also, and in our part of the world where iron deficiency is very common. It's a very effective and good way to get rid of this anemia. So that is called delayed cord clamping at birth. So majority of this maternal fetal iron transfer occurs during the third trimester. So likewise, if the baby is born early, there's more risk of iron deficiency, and also if the mother is iron deficient, so child will get iron deficient. So when in the population, if there are a high number of patients with iron deficiency or mothers with iron deficiency, what you can do is you can supplement them, use supplementation, and also you can use fortification of various food items. So premature infants are at increased risk of iron deficiency anemia due to, like I mentioned earlier, due to less maternal fetal iron transfer, and they have a smaller total blood volume at birth, and we do a lot of procedures on them, so they lose blood in that way, and also they will have poor GI absorption. So all preterm infants should receive some sort of iron supplementation. So how you supplement them, we'll talk about later. So what are the dietary factors? So dietary issues are the primary cause of iron deficiency anemia in infancy and early childhood. So common factors leading to imbalance in iron metabolism include insufficient iron intake and insufficient absorption due to dietary sources of with low bioavailability of iron, such as I will talk in the like later about this heme and non-heme iron, and introduction of unmodified cow's milk less than 1 year of age, which can lead to various forms of blood loss, and then occult blood loss secondary to cow's milk protein induced colitis, and again obesity can also cause iron deficiency. So less than 1 year, so insufficient iron intake is due to breastfeeding without initiation of adequate iron supplementation. So what they recommend is to start so exclusively breastfed babies to start iron supplementation around 4 to 6 months of age. Another thing is formula with insufficient iron fortification. So those who are not on breast milk, if they are on low iron formula or early transition, if you are giving whole cow's milk, it can lead to iron deficiency. So intestinal iron absorption is dependent on form of iron ingested. So this is heme versus non-heme iron. So heme dietary sources are the animal products like fish, poultry, meat, and they have higher bioavailability than the non-heme sources like vegetables and fruits. So the difference is bioavailability in heme products is up to 30%, and non-heme iron it is 10%. And vitamin C also enhances absorption of non-heme iron from the dietary sources. And various food items in the diet can affect the iron absorption. For example, tannates in teas and bran foods rich in phosphates and phytates and plant fiber. And again, children with vegan or vegetarian diets have a higher risk of iron deficiency. Again, they have a higher risk of getting vitamin B12 deficiency. Which can again lead to intellectual impairment, developmental problems, and pigmentation of the hands, and so on. Again, excessive ingestion of cow's milk is also bad. So it can also lead to iron deficiency. All right. So it may be due to low iron concentration in milk. Yeah, and when excessive milk intake when you are taking a lot of milk, there will be occult blood loss from the gut, and even this can lead to protein losing enteropathy. That severe form you can use, like in nephrotic syndrome, we know this protein will leak in the kidney. Like that, protein can leak out from the intestine and give rise to a picture which is called protein losing enteropathy. And prolonged bottle feeding is also a risk factor, because babies who are on bottle feeds tend to drink a lot of milk. As I mentioned earlier, studies have demonstrated higher rates of iron deficiency among overweight and obese children. How this happens? Studies have shown these obese children have higher levels of hepcidin. So as a result, less iron will be absorbed from their duodenum. So what are the gastrointestinal diseases which can affect these iron levels? So as we know, dietary iron is absorbed primarily in the duodenum. Malabsorption of iron can occur in various conditions affecting the duodenum, including celiac disease, which is not very common in our part of the world, Crohn's disease, and giardiasis. And also, babies can undergo bowel resection, and they can have short bowel syndrome. For example, children who had surgical problems, for example, maybe necrotizing enterocolitis in the neonatal period, or resection due to volvulus or malrotation, and so on. So what are the conditions that can cause GI blood loss? So cow's milk protein induced colitis and inflammatory bowel diseases, and chronic use of NSAIDs, aspirin or NSAIDs. So when do we use this aspirin and NSAIDs long term in children? So aspirin is used in conditions like rheumatic fever and Kawasaki disease, and NSAIDs are used in children with rheumatoid arthritis. So how can we prevent iron deficiency? So recommended daily allowance is based on requirements of iron absorbed, and that also on proportion of dietary iron that is absorbed, and estimated iron losses, like mainly in the females, they lose iron due to menstruation. So what is this required daily allowance for children? So in infants, it is 1 milligram per kg per day, and preterm babies need more iron, 2 to 4 milligram per kg per day. So only a fraction of dietary iron is absorbed from our duodenum. So as a result, we have to take a lot of iron containing foods to get that small amount, right? So breast milk contains only a small amount of iron, that is 0.3 to 1 milligram per liter, but the bioavailability will be higher, it's around 50%. On the other hand, iron containing formulas have higher level of iron, but again bioavailability will be low. It's around 4 to 6%. So it is recommended for preterm infants, we have to start them on iron supplements by 2 weeks of age, and then later on we have to start them on food items which are rich in iron. So infants in populations with higher rates of iron deficiency, universal iron supplementation can be used, and these studies have demonstrated with this iron supplementation their growth velocity will improve, and also their neurodevelopmental outcomes will also improve. However, in toddlers and older children, it is not very clear whether the universal iron supplementation is beneficial. And other strategies we can use include food fortification and control of hookworms and malaria, which is not a very big problem in Sri Lanka at the moment. And we have various forms of iron supplementations in Sri Lanka. One is multiple micronutrient supplementation, which is used for smaller babies at 6 months, 12 months, and 18 months of age. And then there's this intermittent iron supplementation for older children. At school, we give them this supplementation at grades 1, 4, and 7. So infants should be encouraged to exclusively breastfeed feed for the first 4 to 6 months. That is the WHO recommendation. If they are receiving more than half of their nutrition from breast milk, we have to start them on iron supplements at 4 months of age, 4 to 6 months of age. And for preterm babies, we have to start them on iron around 2 weeks of age. And how long to give this? You have to give them until they take enough iron in their complementary foods. So for infants less than 12 months of age who are formula fed, maybe due to various reasons, or if they are taking less than half of their nutrition from breast milk, iron fortified formulas which have iron levels of more than 12 milligrams per liter should be provided, and low iron infant formulas are not recommended anymore. And iron fortification of formula is necessary to prevent deficiency, and this usually does not cause any adverse effects. So at 6 months of age, we have to encourage one feeding per day of food rich in vitamin C. So you know the food items, I hope. And after 6 months, and when developmentally ready, you can introduce these meat products. As I mentioned earlier, heme iron is more bioavailable than non-heme iron, and it's also enhance the absorption of heme iron will enhance the absorption of non-heme iron from the food. For infants who are less than 1 year, it is not recommended to feed them with fresh milk, unmodified cow's or goat's milk. So what about children aged 1 to 5 years? So you have to limit the milk intake. So as I mentioned earlier, if they are consuming higher amount of milk, it can lead to iron deficiency. and you have to encourage them to have iron containing foods. So if they are not taking enough iron in their food, then you can start them on iron treatment. So what are the clinical manifestations of iron deficiency anemia? So as you know, in iron deficiency anemia, there will be a microcytic, hypochromic and hyperproductive state in the marrow. So progression from normal iron status, it will progress to iron deficiency, and then iron limited erythropoiesis, and finally they will develop iron deficiency anemia. So you can understand that this anemia develops at the final stage, and again when you start treating them with iron, initially the hemoglobin will go up, levels will go up, then it will take some more time for the iron stores to replenish. So once the hemoglobin levels go up, you don't stop treatment there, you have to continue it for another up to around 3 months for the iron stores to replenish. So what is the most common presentation of iron deficiency anemia? So it's usually a well child, otherwise well child having mild to moderate microcytic hypochromic anemia. Rarely they can present with severe anemia. Nowadays also we see some children coming to ward with hemoglobin levels of 3 or 4, and when we investigated, we find that they are having severe iron deficiency anemia. Sometimes they can present with lethargy, pallor, irritability, cardiomegaly, and poor feeding and tachypnea. And sometimes these certain features are not very obvious, but these conditions like decreased energy, mild pallor, yellow skin, and pica will disappear once you start treating them with iron. So iron deficiency anemia can be caused by underlying medical problems also. For example, GI blood loss and malabsorption syndromes, or chronic inflammatory diseases like inflammatory bowel disease. And again, refractory anemia. So you are treating for iron deficiency, but their hemoglobin levels are not improving. So this is a common presentation for conditions like celiac disease, Helicobacter pylori infection, and inflammatory bowel disease. So it can also coexist, iron deficiency anemia can coexist with other hemoglobinopathies like thaltrate. Quite commonly we see children with thaltrate having iron deficiency plus thaltrate, and also anemia of chronic disease can also coexist. And so as these thaltrate babies can also have low iron levels, so if you provide them with iron, you can initially check their ferritin levels, and if they have iron deficiency, you can treat them, and then they will show some amount of, like, some increase in their hemoglobin level. So what is the effects on neurodevelopmental outcome? So iron deficiency in young children is associated with impaired neurocognitive development, including slower visual and auditory processing. So sometimes some studies have shown that even after you start treatment, these developmental problems can persist, and more severe the anemia, and more worse will be the outcome. So with iron supplementation, the children will show benefits in their like they will show improvement in their psychomotor development. Also, with iron therapy, studies have shown improvements of breath holding spells and conditions like restless leg syndrome and periodic limb movement disorders. And what is the relationship between the febrile seizures and iron deficiency? So several studies have demonstrated that there's an association between febrile seizures and iron deficiency or iron deficiency anemia. So studies have shown significantly lower levels of serum ferritin in children with febrile seizures, uh, and so as a result, it is recommended to check for iron levels. If a child comes to the ward with a febrile fit, we can check their iron levels, or we can screen them for iron deficiency. And iron deficiency can also lead to decreased exercise capacity, and sometimes this can happen without anemia, right? So children with limited iron stores will have poor exercise performance. So the spica and phagophagia are also associated with iron deficiency. Spica is the intense craving for non-food items like clay, dirt, and so on, and phagophagia is the craving for ice. And studies have shown that iron deficiency anemia is associated with cerebral vein thrombosis, and like anemic children are 10 times more likely to have stroke. So the mechanism behind this is not very clear, but as you know, these iron deficient babies, they have thrombocytosis. Why they have a thrombocytosis? That is because their marrow is trying to produce more and more hemoglobin red cells. As a result, platelets are also produced in larger numbers. So this may have a place in COVID-19 also, because this COVID-19 patients, some patients tend to have increased risk of thrombosis. So what are the recommendations for screening? So routine screening is suggested for iron deficiency anemia in infants 6 to 24 months of age. And in the clinics we have to take a good history and examine them, and at least once we have to check their hemoglobin levels. And if these children have risk factors, we can do what is called targeted lab screening. So we can investigate these children with risk factors into in detail. So who are these children? These are the children with malnutrition, prematurity, low birth weight, and dietary risk factors, and obese children, and children who are having symptoms of iron deficiency, and children who are living in areas with high prevalence of iron deficiency. So American Academy of Pediatrics suggests universal lab screening for iron deficiency anemia around 1 year of age, and again to repeat these tests depending on the risk factors. So this is especially important in children who are on exclusive breastfeeding. And studies have shown children who are on iron fortified formula are having less risk of iron deficiency at 1 year of age. However, they can develop iron deficiency anemia later on when they are introduced uh, low iron formula or pure cow's milk or goat milk. So what are the lab tests? So if the history is consistent with iron deficiency anemia, we can do a limited evaluation. So in the form of you can do a hemoglobin level or a full blood count. So what is the typical presentation? These children will be less than 3 years, and they will have dietary risk factors for iron deficiency. Right. What are the atypical presentations? So these are the ones with age range of 3 to 12 years, there are no dietary risk factors or no other possible risk factors, and these children need more extensive investigations. So I have listed the investigations there. So full blood count with indices, so you can see whether there's microcytic hyperchromic anemia, and reticulocyte count will show whether there's a marrow response. Serum ferritin will show the iron levels in the body, and blood picture will show features of iron deficiency as well as other nutritional deficiencies like vitamin B12 or folate deficiency. And again, you can check their stools for occult blood. You have to do it several times. And then you can also check additional tests include serum iron profile, which will include serum iron levels, which will be low in iron deficiency, total iron binding capacity, which is high in iron deficiency, and transferrin saturation will be low in iron deficiency. And erythrocyte zinc photoprofiling will be elevated in the iron deficiency, and soluble transferrin receptor levels will also be elevated in iron deficiency. And we discussed about hepcidin levels in iron deficiency. Hepcidin levels will also be low. So blood level, lead poisoning is also important thing to consider. Nowadays we don't find much like lead poisoning. Sometime back, we used to say, like all paint in all buildings can contain lead, and nowadays children can be exposed to lead through this if their father or parents, and if they are working on car batteries. And fisheries industry, they use these lead balls in the fishing nets, and if there's such a history, then you have to think about lead poisoning. If these tests are consistent with iron deficiency anemia, you can try a therapeutic trial of iron. And also you can do dietary counseling. And if there's features suggestive of GI blood loss or malabsorption, you can start them on iron and refer appropriately. So you have to be careful when you interpret this iron test. And if there's so serum ferritin level is like can go up in various conditions like uh, like liver disease, inflammation, and in malignancy. So it is very sensitive. So sensitivity of serum ferritin is around 97%, but it's not specific. So if there's a concurrent infection, uh, the serum ferritin level can go up. So that's why when we involve patients, when we find when we suspect iron deficiency, we don't do that serum ferritin levels in the acute stage. So we get them down to the clinic and do the serum ferritin levels maybe few weeks later. And one way to exclude concurrent infection is you can do a CRP at the time of serum ferritin. So if when you do serum ferritin, so if the CRP levels are high, then you can say serum ferritin levels may be high because of this acute infection. So other conditions can cause these mild anemias like recent infections, immunization, hereditary or mild hereditary anemias, hemoglobinopathies, and anemia of chronic disease. So I discussed about that earlier, like so iron deficiency can coexist with thal tray. So treatment, how do you treat iron deficiency? So history is very important, and you have to arrange lab testing. So here earlier we were talking about supplementation, and we were talking about low levels of elemental iron. But here when we are treating them, we have to use higher level of iron, like 3 to 6 milligram of elemental iron per kg. So as you know, so iron drops we use in infants. We use iron drops which has a higher concentration of iron, like elemental iron. 1 ml will contain 50 milligram of elemental iron, and iron syrup, on the other hand, 5 ml will contain 50 milligram of elemental iron. So for maximum absorption, you have to give the iron around 30 to 45 minutes before meals, or 2 hours after meals, because various food items in diet can affect the absorption. Uh, right. So for patients with 6 months and older, especially breastfed infants, you have to ensure they consume complementary foods which are rich in iron. And older babies, you have to limit their milk intake, because high levels of milk intake can also lead to iron deficiency. So after starting the iron treatment, you can check the response. Like if it is a mild iron deficiency, you can check their hemoglobin levels in 4 weeks time. If it is moderate to severe anemia, then you can check the hemoglobin rise in 1 to 2 weeks time. And you have to follow up these patients. So if your treatment has been successful, you will see increase of hemoglobin levels by 1 gram per deciliter in 4 weeks, or in moderate to severe variety, you can see them in couple of weeks time. So once I mentioned this earlier also, once the hemoglobin levels have reached the normal value, still you have to continue the iron supplementation for up to 3 months to replenish the iron stores. So before you stopping iron treatment, you can also check the serum ferritin to make sure the iron stores are replenished. So you have to follow them up after the starting treatment. So why most common reason for failure of treatment is that parents are not adhering to this treatment plan. So but if they have been taking the treatment as advised, then you have to think about other like you might have to do a more extensive workup. So in refractory cases, so this condition called refractory iron deficiency anemia, in this situation you might have to use parenteral or IV iron preparations. So this table shows in summary form like serum ferritin levels, hemoglobin HPLC values, and response to therapeutic iron in various forms of anemias, right? I think that concludes my presentation. Thank you very much for patient listening. And if you have any questions, we'll try to answer them now. Thank you.